electrophysiology is very important in assessing causes of visual dysfunction in children. I don't have any financial interest. Basically because children are non-verbal and they don't communicate their problems very well, and amblyopia is also a very important problem to encounter with, to deal with. And hence, I feel electrophysiology has a very important role, especially in causes of visual impairment which are not obvious clinically. Like apart from the anterior segment problems, there are a whole lot of retinal as well as neurological problems which are picked up by electrophysiological tests, or on the contrary, which are excluded by electrophysiological tests, like cortical visual impairment or CVI, delayed visual maturation or DVM, optic nerve head disorders, and retinal disorders. I'm basically going to concentrate on the retinal disorders for want of time. So amongst the pediatric retinal disorders which are picked up by ERG, we have Leber's congenital amaurosis or LCA, achromatopsia, congenital stationary night blindness, cone rod and rod cone dystrophies, and certain unclassifiable conditions. Coming to LCA, it is the commonest cause. In fact, it accounts for 15% of cases of congenital blindness, and Lambert has defined 3 criteria for the diagnosis of LCA. The child should have severe visual deficit since infancy, should have absence of other specific retinal or multisystem disorder, as well as an extinguished electroretinogram. Phenotypically, they can look very dissimilar. If you see carefully, this child has a few chorioretinal atrophic patches in the periphery, chorioretinal atrophic spots in the periphery, and a glossy macula. And this patient has a typical macular coloboma, atrophic lesion, and I don't know why the other one is not opening. These two have basically some amount of disc pallor, but otherwise the retina is more or less normal. And this is the Kurbisfeld, which is a handheld mini Gansfeld. This is a ERG testing of a patient with LCA, and you see that all the responses are flat. ERG is a gold standard in the diagnosis of this condition. Coming to stationary cone dystrophies, I had already showed you in my previous presentation about congenital achromatopsia, how the photopic responses are basically flat. And a few more examples. Normal patient, this is photopic 24 decibel and maximal combined response, which are normal. Whereas you see that the photopic 0 decibel is flat, and so is the 30 hertz flicker. Coming to congenital stationary night blindness, basically it's of 2 types, with normal fundi and with abnormal fundi. Coming to CSNB with normal fundi, it's classified as CSNB only based on ERG, which also gives us an indication about the type of inheritance. For instance, in autosomal dominant type, there is no negative ERG, whereas negative ERG or the Schubert-Bonsham type is seen only in the X-linked type of congenital stationary night blindness. And based on ERG parameters, we classify the Schubert-Bonsham type of CSNB into complete, which is type 1, as well as incomplete, which is type 2. To show you some clinical examples, basically this is what I mean by the electronegativity. You see that the B wave amplitude, the B is much smaller when compared to the massive A wave. And this is a complete CSNB. In complete CSNB, the scotopic 24 decibel is flat, in contrast to the normal patient, and you have an electronegative maximal combined response. And if you see, the photopic responses are more or less spared in complete CSNB. Only thing is, in photopic 0 decibel, you can sometimes get a broad plateau-like A wave, and the oscillator potentials at the ascending limb of the B wave are not much clearly seen. But however, what is the most important thing that we have to understand is that the complete CSNB, the rod function is totally wiped out, and there's a negative ERG, and photopic potentials are more or less all right. And complete CSNB is actually electrophysiologically indistinguishable from MAR, which is melanoma-associated retinopathy. When we come to incomplete CSNB, some amount of rod function is detectable, though it is subnormal. You have a negative ERG, but this 30 Hz flicker is notched, which is classical. In fact, the notched 30 Hz flicker is diagnostic of incomplete CSNB, and you have a subnormal, mildly subnormal photopic ERG as well. Coming to CSNB with abnormal fundi, you have Oguchi's disease, fundus albipunctaris, flecked retina of Kanduri. Oguchi's disease is an autosomal recessive condition. It's a form of CSNB. You have a diffuse golden brown discoloration which reverts back to normal after 2 to 3 hours of dark adaptation, which is called Mizuo-Nakamura phenomenon. And the ERG can very rarely be electronegative, but what is important is the responses revert back to normal after a period of dark adaptation. And similarly in fundus albipunctaris also, it's non-progressive, highly classical, and again after dark adaptation it normalizes, the ERG normalizes. Coming to juvenile X-linked retinoschisis, it's basically a clinically diagnosed condition based on the type of inheritance also, but what is important is ERG has a very important role to play in equivocal cases. For instance, though foveal schisis is almost seen in 98 to 99% of cases, sometimes the sciatic cavities collapse and all you can see is an atrophic maculopathy. And the peripheral schisis is seen only in 50% of cases. So what do? You don't know what that condition is, but you do ERG, you can get the diagnosis. This is a foveal schisis, this is a peripheral schisis, and OCT also shows a lot of splitting here. And the ERG findings are quite typical. You have an extinguished scotopic 24 decibel, an electronegative ERG, and the photopic responses are subnormal and delayed, and the pattern ERG is also flat in keeping with the macular atrophy. So this is just loosely put together so many conditions. This B is very obvious, isn't it? Everything is flat. So this is Leber's congenital amaurosis. So this is basically an electronegative ERG, and this is due to noise. It's not a very good recording. 30 Hertz flicker is more or less normal. So this is a complete type of CSNB. Whereas in this patient, these two, the photopic 30 Hertz flicker as well as the photopic 0 decibel are totally flat, and hence this patient has congenital achromatopsia. All right. So we did a study in which we prospectively evaluated a possible retinal cause of visual dysfunction in children by means of ERG under general anesthesia, about 120 patients. Again, for want of time, I'll just rush through this thing. The ERG was carried out after administration of general anesthesia, and these are the steps of the ERG being recorded. Again, for want of time, I'll just rush through this presentation. So you see the different steps being recorded. And how is the general anesthesia given? The child is sitting on the lap of its mother, so it feels comfortable. You put it in a dark room for about 20 minutes. With some reassuring words from the sister. It's very important that you make the attender sit there in the dark room. Then we enter the data. For instance, now we are trying to analyze a possible case of cone dystrophy. We put some artificial tear drops, and this is a junction box. We use bipolar Burian-Allen electrodes, and the ground electrode clipped to the ear. This is a handheld Ganzfeld, mini Ganzfeld or the Kurbisfeld, and you see that the ERG is being carried out, and time is also taken. The general anesthesia helps us to evaluate the intraocular pressure and the fundus as well. It's only ketamine, so we give a little bit of oxygen to top up, and then some antibiotic eye ointment to prevent corneal problems. And you see that within a few seconds the child is up and awake and ready to cry. So these are the normative values. These are from Arvindai Hospital, Madurai, where I worked as a consultant. These are the normative values, sir. You might be interested in those. And this is again Leber's congenital amaurosis and achromatopsia, what I've already run through. These are the... So basically, the most important fact which I want to highlight is ERG helped us to diagnostically reappraise our diagnosis in many of the conditions, and the conditions in which a retinal problem was categorically ruled out, we were able to refer to a pediatric neurologist and pick up so many cases of CVI and DVM, and the patients got the benefit of the opinion of a pediatric neurologist and visual rehabilitation. So the results, the most important thing is we had a statistically significant correlation and all that. It firmly helped to establish the presence or absence, and it's the largest series to date and the first study in Indian population. And thanks a lot. for your patient hearing.